Hello, Maryview University colleagues and distinguished professors. I'm honored to have this opportunity and excited to be here. My name is Hibajene Chisonga, a Doctor of Nursing Practice candidate. I'm eager to present my DNP project entitled Post-Diabetes Self-Management Education, or DSME, Follow-up Telephone Calls to Improve Hemoglobin A1c. First, I would like to thank my chairperson, Dr. Stegman, who was instrumental in guiding me through the project. In addition, I would like to thank Dr. Brunworth. I would like to thank Nicole Morrissey, manager of Diabetes and Nutritional Center, and also Dr. Miriam Morgan Skinner. Type 2 diabetes is a chronic condition with no cure that affects millions of people, with rates rising at an extraordinary rate. While poor lifestyle decisions bring on some minor instances of the condition and can be treated with dietary modifications and weight loss, most diabetes cases are chronic. Estimates indicate that in adults over 18 years old, the prevalence of type 2 diabetes increased from 6.4% to 9.4% between 1999 and 2016. Type 2 diabetes accounts for 90 to 95% of all cases of diagnosed diabetes. Currently, 26.9 million people of all ages have been diagnosed with diabetes, which is 8.2% of the nation's population. Incidences of type 2 diabetes equal 1.5 million new cases, or 6.9 per 1,000 persons. Uncontrolled diabetes increases the risk for macro and microvascular complications, including certain cancers and the risk of developing some forms of dementia. Diabetes has a high mortality and morbidity rate and is a serious healthcare concern in the US and nationwide. Medical costs caused by diabetes-related conditions are 2.3 times higher than those of patients without diabetes. According to the American Diabetes Association, costs of type 2 diabetes included $19.9 billion from 277,000 premature deaths from type 2 diabetes, $37.5 billion from workday loss due to disability related to diabetes, $3.3 billion from work absenteeism, $2.3 billion from those unemployed, and $26.9 billion due to decreased productivity in the workforce. Discussing the value of diabetes education and encouraging patients to exercise self-care to manage type 2 diabetes effectively is crucial. Overall objective of this project is to evaluate the impact of weekly structured telephone follow-up calls on individual glycemic control in patients with type 2 diabetes who have received diabetes education. The aim was to compare individual hemoglobin A1c at pre and 10 to 12 weeks post-enrollment. The secondary objective was to determine if there was a statistical difference between the comparison groups. Typically, patient education occurs after the patients are discharged from the hospital as an outpatient encounter with the diabetes educator. Primary care providers may not have the time to give thorough diabetes education to patients during their follow-up visits because of limited time and outpatient visits allowance. Increased communication and diabetes education may be accomplished using technology-assisted interventions as a bridge between the patient and the healthcare practitioner until the patient completely comprehends and adapts to type 2 diabetes and effectively manages their illness. The core of nursing is providing evidence based care, including diabetes care to their patients. Nursing plays an essential role in the care of hospitalized patients by ensuring ongoing processes and interventions that produce the best clinical outcomes for patients. Nursing can help improve the diabetes burden by educating the patients on their condition and increasing their quality of life, which is vital in evaluating their well being. The second DNP essential promotes improving patient safety and patient and healthcare outcomes with goals to excel while eliminating health disparities. The project contributed to evidence based research to improve advanced nursing practice as it supports and cares for patients with type 2 diabetes. Across the literature, there were three recurring themes. The first theme was uncontrolled type 2 diabetes as indicated by a hemoglobin A1c greater than 7%. The second theme was the use of telephone calls to follow up with patients with type 2 diabetes to keep patients accountable for their own health and effectively manage their illness. The third theme was an improved hemoglobin A1c because of improved compliance with medication, increased activity, and improved diet choices after a telephone intervention. The health belief model by Marshall Becker served as a theoretical framework for this project. Mr. Becker identified the first four constructs with two more identified by later researchers. The constructs were perceived susceptibility, which is how vulnerable a patient feels to the ailment; perceived severity, the patient's impression of the severity of the ailment and the implications; the patient's perceived benefits, which is the patient's conviction that taking care of their health might lower their susceptibility to the illness or the severity of their condition. And then there's also perceived barriers, which is the patient's impression of the cost outweighing the advantages of acting on their health care. Cue to action is the exposure to illness variables that urge patients to act on diagnostic factors. And self efficacy is the patient's confidence to carry out healthcare tasks successfully. This patient centered model is a theoretical framework for predicting preventative health behaviors and generating treatments based on those predictions. Becker believed that a person's assessment of threat of a health condition and the perceived value of the measures that will lower the danger would drive health seeking behavior. This theoretical framework was used to try and modify participant behavior to help them adhere more to treatments and improve their glycemic control or hemoglobin A1Cs. The setting for the project was the Diabetes and Nutrition Center associated with the large hospital system in the Midwest region of the United States. The department saw a need to improve hemoglobin A1c. It was essential to evaluate if a telephone call protocol would improve hemoglobin A1c and to what extent. The DNP Scholarly Project was a quality improvement project with a quantitative exploratory design utilizing a retrospective chart review of the EHRs to elicit pre and post intervention patient information. So the EHRs are the electronic health records. Patients with uncontrolled diabetes demonstrated by a hemoglobin greater than 7% in the education center were the target of this telephone follow-up intervention. This was an appropriate project design because it compared individual hemoglobin A1c at pre-enrollment and at 10 to 12 weeks post-enrollment for those patients with uncontrolled diabetes who received diabetes education. This design helped in reviewing all EHRs of those referred to the author by the dietitians to determine inclusion or exclusion criteria and also collect data at 2 points of each comparison group. It was determined by the statistician that the project would require 51 EHRs in each group, the intervention and the non-intervention groups. 21 participants verbally consented to the telephone calls and were referred by the dietitians, but only 17 participants were recruited and met criteria for the project. The EHRs reviewed were of patients between the ages of 18 and 89 years old with a hemoglobin greater than 7.0. The intervention group comprised of 11 women and 6 men, 14 Caucasians, and 3 African Americans, and the age ranges for the groups were 30s to 70s. A combination of descriptive and inferential statistics were used for this project. For example, descriptive data characterized 3 data points related to the participants. These were gender, ethnicity, and age range. For inferential statistics, there was only one analysis related to improved post-intervention hemoglobin A1Cs to less than pre-intervention hemoglobin A1Cs. The data collection instrument that was utilized corresponded with the data collection points. Pre and post intervention data was collected in both the intervention and the comparison group. Percentages were utilized for comparison using a Mann-Whitney U test. The intervention and comparison groups underwent the Kolmorov, Smirnov, and Shapiro-Wilks test for distribution normality for this study. The significance of these tests indicated that neither data set had a normal distribution and that both the intervention and non-intervention groups violated their presumption of normality. Instead of a parametric independent samples t-test and due to the abnormality distributed data, a non-parametric Mann-Whitney U-test was utilized to determine the significance of the difference in change in hemoglobin A1c in the intervention and non-intervention groups. This is the demographic data for the project. Figure 1 shows that there were more females than males in both groups. Figure 2 shows more Caucasians and African Americans. And figure 3 shows more 50-year-olds, 50 to 70-year-olds in the non-intervention group and more 30 to 50 and 70-year-olds in the intervention group. At the time of data collection, we did not think that ethnicity would play a role in relation to the hemoglobin A1c, so ethnic data was not collected in the comparison group. Next is a result in change of hemoglobin A1c in the intervention group. So both the intervention and non-intervention groups did show improvement in hemoglobin A1c. However, the outcome analysis of the data collected for this project showed no statistical improvement in hemoglobin A1c when comparing the change in hemoglobin A1c for those who received diabetes education alone to those in the intervention group who received diabetes education and follow-up telephone calls. The data analysis result for the non-intervention and intervention hemoglobin A1Cs did not support the aim of this project. Table 1 shows the results of the Kolmorov-Smirnov test to test for data of normality. Table 2 shows the result of the Mann-Whitney U test, which was used to determine the difference between the two independent groups. The reported asymptomatic significance was 0.571, which is greater than 0.05 and therefore revealed a non-significant statistical difference when comparing the changes in the two independent groups. Neither the intervention nor the non-intervention group had sufficient evidence to show a change in hemoglobin A1c. This is the summary of the Mann-Whitney U test analysis. There were limitations in this project. The project's small sample size is one of the limitations that may have affected the population's representativeness and, consequently, the estimate of the population value. Larger sample sizes result in lower sampling errors and allow for the correction of anomalous data. Because of the size, the sample might not accurately reflect the total population where the research was conducted, since certain patients are more likely than others to be included in the study. The process of recruiting patients for this study may have been a source of bias due to this author's lack of access to a translator. The inclusion criteria for this study exclusively comprised English speakers, which might have constituted a source of bias. So, what does this all mean? The expected outcome was for participants to have a decrease in hemoglobin A1c levels. A data review showed an improvement in hemoglobin A1c in both the non-intervention group, which is the participants who only had the diabetes education, and the intervention group, which is the group that had the diabetes education and the telephone follow-ups. But when comparing the project to previous literature, the results were consistent, suggesting that the use of telephone follow-ups can help patients with diabetes type 2 adhere to treatment and significantly improve hemoglobin A1Cs. But however, this project's statistical analytical results determined no statistical significant difference between the two groups. The evidence clearly acknowledges that while the patient is primarily responsible for improving their diabetic self-care, the primary care provider must adhere to the ideal aim for diabetes by providing ongoing education and incentives. Patients now have easy access to diabetes education because of the development of telehealth-based instructional platforms. By selecting the most effective educational delivery methods, including telephone calls, text messages, video conferencing, emails, online programs, or smartphones, PCPs may close the knowledge gap on diabetes. Telephone follow-ups may be a way to manage type 2 diabetes as healthcare access expands and health information technology develops. The stakeholders for this project include healthcare professionals who provide diabetes care worldwide, patients with type 2 diabetes, and their families who care for them. This project presented telephone follow-up to assist patients with increased healthcare access and self-management skills. Since telephone-based interventions have shown to have better outcomes in other chronic illnesses, telephone intervention is potentially valuable when incorporated with type 2 diabetes education. The project highlights the need for future research on the associations between telephone calls, adherence to treatments, and hemoglobin A1Cs. In summary, The intervention consisted of 4 phone follow-up calls for project participants following their attendance at diabetes education sessions. Participants' hemoglobin A1c levels were anticipated to improve significantly compared to those who got diabetes education alone. Although hemoglobin A1Cs improved in individual groups, the statistical analysis result for this project did not match the anticipated results. There was no statistical difference in the change in hemoglobin A1C between the two comparison groups. A small sample size and a restricted time frame may have been the cause of the difference between the actual and predicted values. Expanding the inclusion criteria to include non-speaking participants would be beneficial in increasing the sample size. An extended amount of time would give participants more time to become used to the changes and allow them to take effect. The repeat hemoglobin A1C in this project was obtained after 10 to 12 weeks, which alone might not have been sufficient to demonstrate a discernible change, and multiple hemoglobin A1Cs over a longer period would allow for interventions to be more effective and allow for the collection of more precise data. Including other ethnic groups could have allowed for a larger sample size, which would have resulted in more data and an increased probability of generalizing results. The intricacies of this project also probably stem from dietitians' failure to provide referrals. It should be used to encourage interprofessional collaboration so that authors such as myself can find alternative ways of obtaining patient referrals. The interprofessional team approach improves preventative treatments, lowers healthcare costs, allows for more individualized patient education, and produces better patient outcomes than care from a single physician. I thank you for the opportunity to present my DNP scholarly project. I am available to answer any questions if they become available. Thank you so much.